Since 2015, Pop Health Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care.
Hello, everyone, and welcome to another episode of Pop Health Podcast. I'm Gavin Ward, host of Pop Health Podcast. In today's episode, I had the opportunity to sit down with Dr. Takashi Wada, the Chief Medical Officer for Inand Empire Health Plan. In today's story, we learn a little bit about Dr. Wada's inspiration behind becoming a physician, how he spent a little bit of time overseas in London with a fun adventure before coming back to the United States and really becoming a public servant where he's serving various communities here in California and now ultimately with Inand Empire Health Plan. In today's episode, Dr. Wada also talks about the new initiative, CalAIM, and how many medi-cal beneficiaries are receiving more supports and care management than ever before, and some things that often people don't think about as directly related to healthcare. We hope you enjoyed the episode. Check out other episodes of Pop Health Podcast by visiting us at pophealthpodcast.com, checking us out on our YouTube channel, Spotify, Stitcher, Apple Podcasts, or wherever you listen to your shows. Thanks and enjoy the show. Dr. Wada, thanks so much for joining the show today.
Great. Thank you for having me.
Absolutely. So on our show, Dr. Wada, one thing we like to do is get to know the guest a little bit before we get into the core reason for you being here today, which is to talk a little bit about IEHP and CalAIM. So let's get to know you a little bit. Tell us something about you that might surprise the audience, preferably something outside of the workplace.
Let's see. I have 3 kids, so that takes up a lot of my time just in kid activities. But I guess the one more interesting thing would be before I became a physician and went to medical school, I did work as a bartender in London for a while. And interestingly, like that experience has really helped me in my various professional roles in terms of being able to listen and relate to people and empathize and hear their stories. So every experience kind of leads you to who you are today. So that was the one that I thought of.
Yeah, that's a really neat one. What took you out to England?
That's a long story.
Okay.
But I wanted to try traveling. I hadn't done much before. I didn't have a lot of funds, but I figured if I went somewhere and actually worked, then I could at least hopefully break even. And so I just went to England, and I was really into music at the time. So got a job as a dishwasher in a pub initially, and then ended up working behind the bar. And this was kind of your classic stereotypical English pub, a lot of senior visitors who would just talk about current events and World War II and things like that. It was a great fun time for me.
Nice. I'm a big soccer supporter, so I'm curious, when you're out in the London area, did you already know what the Premier League was, or did you catch up on any of that?
No, this was I'm dating myself, but late 80s, early 90s. So,
okay.
Yeah.
Awesome. Well, it sounds like you weren't there long enough to pick up an accent, but
yeah.
Awesome. Well, hey, a great story. Let's get to know a little bit more about your background before we jump into Inand Empire Health Plan, or IEHP, and CalAIM. So give us a little bit of background, Dr. Wada, where you grew up. I know we'll talk a little bit about how you ended up in Santa Barbara. But yeah, give us a little background about yourself, where you grew up, and ultimately how you chose medicine.
Sure. Born and raised in Southern California, initially around the MacArthur Park area, west of downtown, but most of my schooling in junior or senior high school was all in Culver City. And I know your team has some ties to Culver City as well.
Yeah.
So that's where I was raised primarily. How did I get into medicine or become a physician?
Yeah.
So unfortunately, after I was born, my mother became inflicted with a fairly severe progressive rheumatologic condition. So there are no professionals in my family, but I was around the medical community a lot through my mother, and she would be hospitalized, quite often at UCLA. So even from the earliest ages, I was running around the halls of UCLA Medical Center and eating in their cafeteria with my father. And so a lot of the medical staff knew me, and I think as a young child, you're very impressionable, and they're the doctors with their white coats trying to help your mother, and that was my target goal from a very, very early age.
Wow, what a strong connection there. So you go to UCLA. I mean, your mother received care there, but you actually even ended up going to school there. So I guess, was it that familial experience that made you choose UCLA, or?
Yep. Actually, that was the only medical school I applied to. It was that was dead set on going to UCLA for that. So.
Got it. So are you rooting for the Bruins at all? We got March Madness coming up.
Big Bruin fan.
Yeah.
When I was there, I was one of the students who would do face paint and stuff like that at camp overnight for basketball tickets. So yeah,
oh yeah,
big Bruin fan.
That's awesome. They had the rivalry game. I know that's, people think of that more football, but basketball even as well, as we're recording this. Two really good teams right there.
Yep.
So you go to UCLA. You experience what you experienced with your mother at a young age. Then you decide, while you're becoming a physician, to opt to serve the community. Tell me about that. What made you choose to go the service route versus potentially, some folks can go different routes and make significant, incomes. Tell us about that.
So I ended up going to primary care as a family doctor and working in underserved areas, community clinics, mostly providing care for the homeless and immigrant populations in the same community that I grew up in. So some of my patients were kids or teenagers that went to the same schools that I did, and I just felt that was something that I wanted to do, and was really rewarding for me in terms of giving back. And also worked some internationally in Mexico, Central and South America. And so that element of medicine is just something that has carried me throughout my career.
That's awesome. Do you mind me asking, when you did the international work, was that more mission work or service oriented work, or was that actually you actually stayed down there and that was a primary source of income?
No, I was not paid for that. So the way I had my contracts arranged here was that I would be working in the community clinic for most of the year. I was teaching at UCLA, but then I reserved 2 to 3 months a year to do international work just on my own. And so I would go and work in those other countries as a physician.
Wow, I have a lot of, this is very touching. I have a lot of questions. We don't have enough time for what sure. I'm sure the stories and more about your heart, but that is really very neat, Dr. Wada. And looking forward to learning more, maybe off air, about that. So,
sure. Yeah. No, again, great experiences. I often learned just as much from those people and places than I contributed, just in terms of what life has to offer and what's important. So, great experiences.
Awesome. So eventually you end up going up to beautiful coastal Santa Barbara, which is a special place for me. I went to school up there, a little place called Westmont College, which a lot of people have never heard of. And like, is that an all boys school or junior college? But yeah, Santa Barbara has a special place for me. So tell us what brought you up there and eventually how you ended up at IEHP, which is inland.
Sure. And so I was working in the community clinic, free clinic setting, seeing a lot of the undocumented, and this was in the 90s, of course, before the Affordable Care Act. So there were quite a number of uninsured, not undocumented, uninsured individuals. And, you're in medical school, you're sort of taught how to, diagnose and treat people, but it's sort of separated from the reality of what you have to deal with when people don't have insurance and don't have great access to quality health care. So, those sort of frustrations with the system and sort of inequities led me more into public health. So I got more involved in public health policy. Served for a little while as director and health officer of Pasadena's health department. And then I got a job heading the County of Santa Barbara's health department. So we moved up there. My wife's family was in Santa Barbara County. So as we started to have younger kids, closer to family, it was a good career opportunity for me. And so I went up to Santa Barbara County, overseeing their health services department, also for a while their behavioral health department, and their federally qualified health center services.
Okay, awesome. I have to admit, I didn't know what a FQHC was up until probably 3 or 4 years ago. So every time I hear the term, I'm like, okay, I know what a federally qualified health center is now. Yeah. So awesome. So you're up there for a few years, and then you go from the coastal Santa Barbara to an opportunity with Inland Empire Health Plan. What drew you out to the IE or Inland Empire?
So when I was up in Santa Barbara, unfortunately, my father was diagnosed with pancreatic cancer. Amazingly, he's doing well to this day, but at the time we didn't think his prognosis was very good. So we made a family decision to move back to be closer to help support him. And so my kids could have some quality time with him. And at the same time, it was just extremely fortunate and blessed that an opportunity opened up with IEHP. And IEHP had a great reputation for innovation, doing some wonderful work, doing the right thing. And they just happened to have a senior leadership position that was available. I had gone to UC Riverside as an undergraduate, so I knew the area a bit. And it was just a wonderful, great opportunity for me career-wise as well.
Yeah, from one Nisbet County to the other. Well, it's great to see how your parents, how you've been there for them, and they've obviously played an important part in your life. So with Inland Empire Health Plan, can you give us just a brief overview? Our audience is a national audience. Many are actually here in California, but they may not be too familiar with IEHP. Tell us about IEHP.
Sure. So Inland Empire Health Plan, it's a public Medicaid managed care plan. And here in California, it's called medi-cal. And so we provide that, we administer that program to about 1.5 million residents in Riverside and San Bernardino counties. And we've been around for about 25 or so years, started very small, 60,000 members here in the area in the 2 counties. And of course, that's grown over the years through the Affordable Care Act to where we're now providing that oversight for almost 1.5 million residents.
Yeah, and I think from a land size, I was talking to one of your colleagues off the air. I know you're one of the largest in California, but from a land size, you might be the largest. Do you happen to know, Dr. Wada, if geographically it's the largest area for coverage?
I don't want to say for sure, but yes, they're definitely 2 very big counties. And so, our network, we have, I think, some 8,000 doctors and providers that are working with us. We have about 2,500 or so employees. So yes, we cover quite a range of geography.
Yes, and you're about 25 minutes from my house. I've been to your headquarters there in Rancho Cucamonga, and I actually have a few friends who foster children. And I know, if I recall correctly, IEHP helps provide the coverage for foster kids in the Inland Empire. Do I have that right?
We do, yes. Oh. Foster kids, medi-cal, of course, services all ages. We do some Medicare, some dual eligible populations that have both medi-cal and Medicare. So we do support all of that.
Great. So one of the reasons we wanted to really bring you on, being a CMO for one of the largest plans here in the state, is to talk about CalAIM. So can you give our audience a quick overview of what is CalAIM and why it might be important to our audience of healthcare professionals?
Sure. So CalAIM, it's actually an acronym. Most people aren't necessarily aware of that, but it's California Advancing and Innovating Medi-cal. It's a multi-year initiative through the State Department of Healthcare Services to really sort of transform the Medi-cal program. So in the past, a lot of healthcare is really focused on the care that's provided sort of within the walls of facilities, within hospitals, within clinics. But from my public health background, and I think a lot of your audience would certainly understand if they work with the population, you have to think of health much more broadly. And so through CalAIM, it's really kind of moving us outside of those walls. It's supporting community-based enhanced care management teams to kind of wrap services around our members or individuals with sort of the highest needs. It's promoting a lot of what's called community support services that's really allowing us to address some social determinants of health. And there are a lot of other aspects to CalAIM. There's multi components around expanded geography, trying to develop a more seamless integrated system, bringing in behavioral health integration, population health management. So there are a lot of different pieces to CalAIM, but I would say kind of overall, those are some of the sort of broad aspects of the initiative.
Yeah, thank you very much. And I know there's significant funding as well. So audience, I've kind of plugged in a little bit to CalAIM over the last few months, not as skilled or knowledgeable as Dr. Wada. But one of the cool things that I see out there is something called housing deposits, which is one of the community supports. I know IEHP is involved with that. Could you, and I know you're not, you may have a person on your team who's the housing deposit guru, but can you give an idea of maybe why the housing deposit is something that a medi-cal plan should be involved with, or why is financial assistance with medi-cal or with IEHP?
Yeah, no, absolutely. And I would qualify it a little bit by saying for the community support services, every managed care plan was able to choose what they wanted to implement. So it may not be the same with every health plan and in every region. The state gave us a menu of 14 or so that we could choose from. We decided to implement 11 of those, which I think is one of the most throughout the state. And There is a housing bundle. So as a managed care plan, and again, we're a public plan, which gives us a little bit of different perspective because it really allows us to focus on our members and the quality. We don't have some of the financial pressure around stakeholders and things that a commercial plan might have. And so, above all, we exist because of our members and trying to keep them healthy and for those that are ill to try to get them better. And a lot of that focus in the past has been in some of the transactional work. That's kind of how managed care started, contracting with providers, overseeing the billing and things like that, making sure you had a good network of providers and contracts. But really over time, it's really shifted focus into really trying to push the needle on quality to make sure that our members, get the access and quality that they deserve. And so a big piece of that, though, is getting, again, sort of upstream. So it's very difficult to improve someone's health when you're only focusing on what happens in a hospital or a clinic, when that same individual then sort of leaves that facility and is faced with homelessness and food insecurity and, all the different biases that exist in society. So with CalAIM, it now allows us to support some of those programs that address social determinants of health. So you mentioned the housing deposit. So we're not able to pay for housing just indefinitely, but as a health plan, we know that if we want to keep our members healthy, keep them on their medicine, keep them out of the hospital, we have to address some of these other impacts on their lives as well. So we can pay just for the initial deposit. There's housing navigation and tenancy services where we can get them connected to, say, county programs around housing vouchers and things like that, other housing programs. There's short-term post-hospitalization housing and recuperative care.
Yeah.
So if someone is in the hospital and say they're homeless and they need somewhere, they don't quite qualify and meet criteria to be in a skilled nursing facility, but you can't put them back out on the street or they're just going to end up right back in the hospital again. So we now have the ability to cover sort of that bridge period.
Mm-hmm.
And so, and then once somebody's in housing, there's sustaining services that we can support as well. So sometimes an individual who's hasn't been housed in a long time, it's not easy for them to follow rules, and sometimes they get afoul of landowners, landlords, I should say, and so it's important to help support them with those wraparound services. Just how do you pay the bills? How do you follow rules and things like that? So there's a whole housing bundle of services that we're able to now support through our community partners.
Yeah, that's great. So we talked about the housing, there's transitional care, there's personal care and respite additions besides just in-home support. I mean, like you said, there's 14 community supports, used to be known as in lieu of services. So can you tell us, let me backtrack a little bit. So my day job is in healthcare related field. And one thing that I've found when it comes to contracting or being a service provider with a government entity is usually there's all these strict rules and you have to do it this way, you can't do it that way. And one thing I've noticed with CalAIM is there's actually some flexibility built in to these service providers for some of these new services. Tell us a little bit about, well, let me backtrack. While the contract might be pretty straightforward, the actual delivery of care, there's not all these specific ways it has to be done. Tell us about that. Why so much flexibility with CalAIM?
There is some flexibility, and there are, of course, some rules as well. And so, one of the challenges is that we have all these great community partners and vendors to provide all these services, and we've sort of been working on building out that network. But some of them haven't been involved, as you said, in the medi-cal program. They're not used to all the rules on how to submit authorization for approval, how to bill and through claims, what forms do you use, how they're closed loop systems so that we can make sure that someone who is referred is going to actually get the service. We need some verification of that. And so, our job as a health plan is to make sure that those providers and those vendors are supported and understand how to do all of that, so that we can down the road evaluate and make sure that these provided good value. These are taxpayer dollars, and we're stewards of that. So we need to make sure that we're getting good outcomes and tracking everything. So that's all important. There's a lot of reporting and data and paperwork that's for sure, but these are really important services for our members.
Yeah, and those are all good points. I will have to say, you mentioned the word supported. And as I mentioned, in my quote unquote day job, I have, the different plans have been very, very open to ideas. So it's really cool to see the health plans, jump in and work hand in hand with the providers and be all ears of how the providers can solve some of these problems. So can you walk us through, I know we're only a couple months in, so audience, CalAIM officially was live, and correct me if I'm wrong with any of this, Dr. Wada, January 1st of this year. And like Dr. Wada mentioned, not all plans have enacted all the community supports, so it's still pretty early. There's also only certain medi-cal populations that are currently available. So we won't go into all the details, but over time, other medi-cal populations will have access to CalAIM, but today it's not everybody. So are you able to share with us maybe an early win here in 2022 and maybe some of the challenge that you're still having? Would you mind sharing? Let's start with the win.
Yeah, I'd like to qualify that the community supports are available to the medi-cal beneficiaries, but they do still need to meet individual criteria for that particular community support. And there are some limits as well in terms of how often they can get them. But it is available to everyone who has Medi-Cal, depending on your county as well as your Medi-Cal plan. But the enhanced care management, which is another big piece, these are the community-based teams that are providing a lot of those support. So for us, there's like a nurse care manager, there's a behavioral health specialist, a community health worker. And one of the big issues with this population is sort of trust. So we built in community health workers that are part of the community to help work with those individuals, again, out where they are. Those enhanced care management benefits and those teams are restricted to certain populations. So you're either going to be homeless or high utilizer of services, have severe mental illness or substance use disorder. Those are the populations of focus that went live January 1st on the enhanced care management side. And you're right, subsequent populations are going to fold in 2023. So individuals who are transitioning from long-term care back to the community or trying to keep people in the community from going into long-term care, complex children, those subpopulations of focus go live in 2023.
Great. Are you able to share with us maybe an example in the first couple of months of where one of these supports or ECM, even enhanced care management, has seen some good results, or at least anecdotally?
Yeah, well, the enhanced care management program is actually built on a prior program called Health Homes that a lot of different health plans and counties participated in, and also the county whole person care programs. So a lot of the individuals sort of grandfathered over from those programs. And in that program's existence and now transitioning to enhanced care management, since we maintain the same model, we've actually done some evaluations that have demonstrated really good outcomes in terms of blood pressure control and increase number of screenings for depression and things like that. So we've already gotten some good clinical outcomes. On the housing side, IEHP already had our own housing program, and so that sort of gave us an advantage. We had already been doing a lot of that sort of housing wraparound support, and we have tremendous stories about individuals who had previously been experiencing homelessness and then were able to get into a place and felt supported, and then just saw their health or clinical numbers just improve dramatically, whether it was high blood pressure, diabetes, and things like that. So, and there are a lot of other community support services. You mentioned asthma remediation. So it's basically the same thing. If somebody comes in with asthma, you treat them in a hospital or you treat them in a clinic, you give them medicine, and then they're going back to their home environment with all the asthma triggers and allergy things. And now we have a way to address that as well. We can support air filters in the home if their carpets are moldy and need to be replaced because it's triggering their asthma. We can do things like that. So yeah, there are a lot of great opportunities for CalAIM, and we've already experienced some of that.
Awesome. Well, it's great to hear those early wins, and I appreciate the background on the California Health Homes and how you had housing already in place, unlike a lot of other plans. What about some challenges as you try to leverage these resources into a new program? What are some of the, I don't know if barriers is the right word, but yeah, tell us about some of the challenges or a challenge.
Yeah. So I'd say one of the challenges is, even when you have great programs like this and there's actually funding to do it, sometimes you can't find the people.
Yeah.
As we started out, Riverside and San Bernardino County are huge geographic areas. And when you're getting into some of those more rural parts of the county, it's definitely difficult to find staff. Nurses or behavioral health person, that's definitely challenging. So we have a lot of willing partners who would like to stand up these teams and provide the services, and they just can't find qualified people. Yeah,
and I wish we had a magic solution for that, but that has been one that I think a lot of us can relate to. So one thing that DHCS is wanting all of us here in California, and I'm sure obviously across the country, is just the whole access and equity issue, access to care, making sure folks have access to healthcare that's equitable versus the rest of the population. Can you tell us some of the steps that you guys either have taken or are planning to take to really bridge that gap to ensure that quality access and that quality care for all populations?
Yeah, no, absolutely. This is a big focus from the state. It's also been a focus of ours because we do see those disparities, whether you're breaking it down by race, ethnicity, or by geography. This was magnified by COVID. COVID is having a huge impact on our populations, on our workforce as well, but also on our membership. And we saw, big differences in terms of whether it's vaccination rates or death rates. There's big discrepancies there by race, ethnicity. So it's something that we are very much focused on. IEHP has our own strategic plan that we've been working on. And a big part of that and core to our sort of mission, vision, and values is the idea of health equity. So,
okay.
I think it starts out with, we have all these different clinical metrics that we follow, whether it's, again, control of blood pressure, diabetes, are people on the right medicines and things like that, getting the right screenings, immunizations. But one of the key things is awareness that these disparities exist. So we break them all down by race, ethnicity to identify the biggest gaps. And then we work to develop program or through our provider network, have these more targeted programs and efforts and interventions to try to reduce those disparity gaps.
Yeah, that makes a lot of sense. One thing I'm learning with plans like IEHP is just the investment into translation as well. I know they're in the Inland Empire, obviously English, Spanish, but I know you guys make translation services available, which I think is a cool investment. Forgive me for not knowing, but I remember you guys won some type of award that I saw recently that addresses this issue as well. So it's pretty cool to see some tangible things that you guys are doing. So we went through this pretty quickly, Dr. Wada. I have my notes here and questions I wanted to ask you. Is there anything you think we may have missed that the audience should know, keeping in mind our audience are mostly healthcare professionals?
Well, I think the big, key takeaway from CalAIM and a lot of our efforts really is, working to address the social determinants of health. Big piece of that is trust out in the community. So that's something that we're really working on in terms of engaging our populations. Because when you are focused, and we have to do this, of course, but you focus on quality and access within hospitals or within clinics, but we still have a lot of our IEHP members, and there are a lot of medi-cal or Medicaid members across the country who aren't engaged in the healthcare system at all. Or they come in too late after their disease is already more advanced. And so we really need to find a way to engage out in the community. I'm a big supporter of that, and address some of these social determinants of health. We're working a lot with, as I mentioned prior, community health workers to kind of build that trust. I mean, with COVID, I know it got very politicized, and there are a lot of different reasons for that. But so much of that was mistrust and miscommunication, misunderstanding, misinformation. And so we really tried to mobilize a lot of our community partners, whether it's the faith community or schools, or just trusted community leaders, business leaders, just trying to think sort of non-traditional, who can help us get the message out about getting in for these really important services that are going to keep our communities healthier and our members healthier.
Yeah, great point. And I think as we close up the show today, one thing that stands out to me with what you touched on is the whole phrase community health worker, which has really gathered steam. And there's stakeholder committees here in California and across the country to really formalize what that term community health worker means and how we can create an infrastructure and development for community health workers who are folks that are not necessarily licensed medical professionals, but as you mentioned, know how to build trust in the community. So great points, Dr. Wada. If folks want to keep up to tabs on what IEHP is up to, what is the best way to follow on the website, LinkedIn? How do you guys best communicate to our listeners?
Yes, probably website. I know our CEO gets a lot of messages out, so he's a great person to follow. That's Jared McNaughton. He's a great leader for us. But yeah, those are some ways that people can keep track of what we're up to.
All right, awesome. Jared was actually instrumental in connecting me ultimately to you as the CalAIM expert. So, Dr. Wada, it's truly been a privilege hearing about your heart and your service. You mentioned 2 to 3 months a year where you're out serving the community. That was really touching. Folks, Dr. Takashi Wada, who's the Chief Medical Officer for Inand Empire Health Plan, has been our guest. Dr. Wada, thank you so much for your time today.
Great. Thank you for having me. And it's great service that you do through these podcasts.
Thank you very much.
Thanks, everyone, for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.